Hi and hello everyone, this is your Dr. Bharat Kumar VD, Pharmacology faculty. In this video, I'll be discussing the recently conducted FMG July 2025 and we'll be discussing the pharmacology questions here. So this will be a beneficial video for those who are undergoing exam in the future, particularly for FMG and NEET PG. And those who are taking up the NEET PG in August 3rd, they will also be beneficial. Some questions may repeat from this discussion also. So let us start. The first question is, a 67-year-old male patient complains of excessive thirst and increased urination. So patient is having polyuria and he has excessive thirst. So he will drink more water, polydipsia. Correct. Around 6 to 7 liters per day he is passing the urine. He has a history of cerebral trauma 1 month ago. Which of the following is the most appropriate treatment in this patient? So when we think of polyuria and polydipsia, two diagnoses comes to our mind. One is diabetes and one is diabetes insipidus. Diabetes, there will be polyphagia also. So it is only given as dipsia and urea, so it is diabetes insipidus. Since the patient had a cerebral trauma, there can be damage to the hypothalamus, so there can be a problem in ADH secretion, so there is no ADH production, so this is called as central diabetes insipidus. So the question is asking more of clinical way, what is the drug used for managing central diabetes insipidus? So I told you there is no ADH production. Then what to do? Give ADH. And what is the ADH we give? The ADH we give is desmopressin. Desmopressin is a V2 receptor agonist. So this can be given. Insulin has no role unless it is diabetes. It's not diabetes, diabetes insipidus. Thiazides, they are the drug of choice for peripheral. Peripheral, also called as nephrogenic diabetes insipidus. Tolvaptan, it is a drug of choice for SIADH, syndrome of inappropriate antidiuretic hormone. Since the question is, what are the clue to come to the answer? The cerebral trauma, polyuria, polydipsia, that will point towards central diabetes insipidus. So the answer for this question is D, desmopressin. I hope most of you have answered that correctly. And we have discussed plenty of times in revision in the regular classes. Moving on to the second question. A 55-year-old male patient present with arthritis, that is inflammation of the joint, and has coronary artery disease. He has a history of peptic ulcer disease. Which of the following is the most appropriate anti-inflammatory drug? So patient is having problem of arthritis, patient is having coronary artery disease, and patient also has peptic ulcer disease. So I have to manage arthritis, then I have to give NSAIDs. So they are asking in the exam which one is best. So the options are ibuprofen, naloxone, diclofenac, celecoxib. I think the option is not naloxone. I think it should have been naproxen. Now, why we are worried? See, whenever we give NSAID except aspirin, all other drugs increase the thrombotic events. They increase the thrombotic events, which can lead to the MI and stroke. So all other NSAIDs can increase risk. So in this, ibuprofen is NSAID, diclofenac is NSAID, and celecoxib. These are selective COX-2 inhibitors. They are also known to increase the thrombotic event because they decrease the level of PGI2 without affecting thromboxane A2. So the best NSAID what I can prescribe is either I can give aspirin or I can give naproxen. So the question is either I should choose aspirin or naproxen in this patient, but whether you give aspirin, naproxen, both can increase gastritis. So that is why I told you we are doctors, we need to take decisions. Now the risk is coronary artery disease, the risk is peptic ulcer disease. So which is the dangerous one? The dangerous one is coronary artery disease. So should I get worried about peptic ulcer disease? No. So the thing is, first of all, I need to think about coronary artery disease. So avoid all other NSAID except I can prescribe aspirin, naproxen, because they have less thrombotic problems. So I can choose them. But there is a risk of peptic ulcer disease, but I can manage that with PPI. So the best option would have been naproxen for this patient, even though there is a risk of peptic ulcer disease, gastritis, but I want to manage, I want to take care of coronary disease. So the answer will be naproxen. And obviously celecoxib should never be given. We have discussed in the class plenty of times regarding this. Moving on to the next MCQ. Which of the following is used as abortive treatment in a patient with cluster headache? Now, cluster headache is a severe form of headache one side behind the eye, radiating to other places. So immediately, if you want to stop this, there are two treatments. One is you give oxygen, that is 100% oxygen can be given, or with that you can add triptans. So the triptan commonly used is either you can give sumatriptan. So triptans are the drug of choice. Sumatriptan, which can be given as subcutaneous injection, or we have another triptan called zolmitriptan, which is given as nasal spray. So this will act faster and they can be used to manage this. So earlier exam, they had asked what is the drug of choice for cluster headache. They had given triptan. This time they are not given the option triptan, they are given oxygen. So from the option, oxygen will be the best answer. Topiramate, propranolol, they are for mainly migraine prophylaxis. Verapamil is again a drug for prophylaxis of migraine also. And also it is a drug for prophylaxis of cluster headache. Not to abort an headache. Not to abort an headache. Right? Why it will not abort an headache? Because it's a vasodilator which will worsen that. So remember, it is used for migraine and cluster headache prophylaxis, not to abort. So the best answer will be oxygen 100%. That is the one. See, this is how the questions evolve. Earlier they had asked the drug of choice triptans, then oxygen. Now they are asking. So any other drug I can give for aborting this headache? Yes, you can also use ergots, dihydroergotamine. But the drug of choice is triptan, and the additional therapy is oxygen we can keep. Moving on to another MCQ. 65-year-old male presents with hypertension, also has proteinuria and CKD. We have discussed this plenty of time. Hypertension with comorbid condition. Which of the following is the most appropriate antihypertensive drug? So the answer is option A, telmisartan. Telmisartan is an ARB and it is beneficial to manage hypertension. It reduces proteinuria and it's also beneficial in CKD patients. So you can prefer in a patient with hypertension, with diabetes, hypertension with CKD, and hypertension with proteinuria, you can prefer this AC inhibitor or ARBs. Spironolactone is not going to reduce proteinuria. Propranolol is a beta blocker that will not help here. Thiazides will not help here. So the appropriate answer would be telmisartan. Moving to another MCQ. Which of the following is the correct treatment for H. pylori infection or eradication? So H. pylori eradication, we use either 3 drug, that is called triple drug regimen, or we use 4 drug. I have told repeatedly in the class, we will give PPI, then we use the mnemonic ABC, trademark limited. So we give PPI, amoxicillin, bismuth subcitrate, clarithromycin, tetracycline, metronidazole, and recently levofloxacin. So we don't give only OPA, that is omeprazole only. We don't give antibiotics only. We give not only give antacids, we give triple drug regimen. One should be PPI and 2 antibiotics. So here the option should not be ampicillin, it should have been amoxicillin. So it is amoxicillin plus metronidazole. I don't know the options. Remember, we use 3 drugs. The regimens are either OCA, omeprazole, clarithromycin, amoxicillin, or OCM, omeprazole, clarithromycin, metronidazole. I don't know which is the best option given in the exam, but this is the regimen, triple drug regimen we use. So clarithromycin with amoxicillin, clarithromycin with metronidazole. This is the triple drug regimen we can use. And the duration of treatment is 14 days. So you check your question and you check your answers. If you are marked at OC or OCM, then you are right. And these are the antibiotics what we use to manage H. pylori. So if I want to write what is the most appropriate answer will be omeprazole plus amoxicillin plus clarithromycin. If it is there, then also your answer is correct. Or if it is omeprazole plus clarithromycin plus metro, if they are given this option, then that is also correct. Okay, sir. Now coming on to the next question. A 19-year-old female is a known case of bronchial asthma. She is on inhaled corticosteroid and LABA, long-acting beta-2 agonist, formoterol. She continues to have exaggerations and FE1 is normal. There is no improvement by giving salbutamol challenge, and it is worsening seasonally. Ig levels are more than 200. Which of the following is the most important next step in managing this patient? Now, there are guidelines for asthma, the GINA guidelines. The GINA guidelines, if I want to simplify, we give inhaled corticosteroid at low dose. If it is not controlled, we give inhaled corticosteroid with LABA. And still not controlled, we increase the dose of inhaled corticosteroid and give LABA with that. So still not controlled, then we go to other therapies. We add the other therapies like LAMA. We can give the anti-IgE therapy. You can block IgE, you can block interleukin 5, you can block interleukin 4. So these are the other options which we have. So patient is already in a corticosteroid, LABA not controlled, salbutamol is also not helping, and you see the IgE levels are very high. What is the drug which blocks IgE? The drug what I need to give is omalizumab, which is given subcutaneously. Now IV steroid, they are for emergencies like status asthmaticus. IV terbutaline is also for emergency like status asthmaticus. Adding SAMA will not help because you see salbutamol is a SAMA which is not going to do much help in this patient. So the appropriate answer would have been add omalizumab subcutaneous. So even this question repeats in the future. Remember, we give inhaled corticosteroid in the beginning, and if it is not controlled, we increase this dose gradually and add LABA. Then still not controlled, increase the dose of inhaled corticosteroid and keep the LABA same. Still not controlled, we have other options. You can add LAMA, you can add IgE blocker, interleukin 5 blocker, or interleukin 4 blockers like that. So in this, the appropriate would have been add omalizumab subcutaneous. And the point which points towards choosing that is the level of IgE. Correct? Yes. Again, pharmacokinetic questions, usually they don't give in FMGs. Very rarely we have seen that, but now the standard has been set for NEET PG level FMG exams. A male patient weighing 70 kg is administered drug with half-life of 3 hours. Volume of distribution is 100 ml per kg. What is the approximate clearance if I tell it is in ml per minute of the drug? What is the approximate clearance of the drug? So they are asking in ml per minute. So how to do this calculation, whether the values are correct or not, let us see. There is a formula called T half is equal to 0.693 into volume of distribution divided by clearance. To make the calculation simplified, so we take this 0.693 as 0.7. And how to calculate volume of distribution? They have given volume of distribution is equal to 100 ml per kg. Since the patient is 70 kg, so I will multiply by 70. So this will become 7000 ml. So it will be 7000 ml. So the volume of distribution will be 7000 ml and divided by half-life. The half-life they have given is 3 hours. Okay, so let me do like this. Let me write half-life here, 3 hours, and let me write clearance here. Now if I want to calculate clearance, clearance will come here. So clearance is equal to 0.7 into 7000 ml divided by 3. Divided by 3. 3 is in hours, correct? So 0.7 into 7. 7 sevens are 49. So it is 4900 ml per 3 hours. So if I divide this 4900 by 3, how much I get? How much I get, sir? So how much I get is 3 ones are 3, 3 6 are 18, and then we have 1 3 3.0, but it is per hour. It is per hour because we are taking it as hour, but here the options are given in ml per minute. So if you want to get ml per minute, 1663 per hour, how to get it? It is 1663 ml per hour. How to get it? 1633 should be divided by 60, so you will get ml per minute. You will get ml per minute. So approximately, let me calculate that. If I do like this, so it is 2, 6 2s are 12, and 4 6 7s are 42, 6 7s are 42, and point something, so it will come around 27. So it will be around that 27 ml per minute, like that. So if I come to the closest answer, it will be around 23 ml per minute. 23 ml per minute. So approximately I got 27 ml per minute. So very complicated equation. I don't know how you people did this without the paper or a sheet in front of you, but those who are seeing this video, let me explain again. The formula what we used is half-life is equal to 0.693 into VD by clearance. The half-life is given as 3 hours. We know we have approximated 0.693 into 0.7, and VD is calculated 100 ml per kg, that is 100 ml into 70 is 7000 ml divided by clearance. So we took clearance here, 0.7 into 7000 divided by 3, that is 7 sevens are 49 divided by 3. So this will be around 1633 ml per hour. But if I want to convert that ml per hour into minute, I have to divide by 60. So then you get approximately 27 ml per minute, like that. So that would be the answer here. Okay. So if you have to do the calculation in a proper manner. Clear? Yes, sir. Now coming to the next question. A 65-year-old male patient developed Achilles tendinitis and leg swelling after taking antibiotic. Which of the following is the mechanism of the probable antibiotic taken by the patient? So if you know the adverse effect, you know it causes tendinitis and patient is having leg swelling, has taken antibiotic. Tendinitis, tendon rupture is produced by fluoroquinolones, and they are asking what is the mechanism of fluoroquinolones? The mechanism is they inhibit DNA garase and DNA topoisomerase 4. Drugs inhibiting protein synthesis, we have discussed plenty of time: tetracyclines, aminoside, chloramphenicol, macrolide, clindamycin, streptogramins, linezolid. Folic acid synthesis, we have sulfonamide, then PAS and dapsone. Bacterial cell wall synthesis, two major drugs, beta-lactams and glycopeptides like vancomycin. So here the answer is A, and we have discussed plenty of times in our revision and classes. Moving on to the next question. A pregnant woman presents with headache and decreased vision. MRI shows a pituitary macroadenoma compressing the optic chiasma. The best treatment will be to do surgery, but she is pregnant. We don't want to take the risk of doing the surgery. And what is the drug of choice for managing this patient? So pituitary macroadenoma, maybe it is going to lead to prolactinoma. So what is the treatment for prolactinoma? They are asking. Tamsulosin is a drug used for BPH. So the answer would be bromocriptine, and it is better in pregnant women. So without non-pregnant women, or in a non-pregnant woman, if they ask you what is the drug for prolactin, then I will go for cabergoline. The reason is cabergoline is longer acting drug. We'll go for that. Octreotide, it is mainly used for esophageal varices and acromegaly. Leuprolide is a GnRH agonist. So for this, the major treatment will be bromocriptine. Coming on to the next MCQ, a 72-year-old male patient, hypertension, tachycardia, and early renal involvement is prescribed in ERB, telmisartan. I think this time most of the questions are on hypertension ERB. What is the likely mechanism by which the drug helps improve heart rate and blood pressure? See, what is telmisartan? It's an ERB. So what does it block? It blocks it blocks mainly angiotensin 2 action, particularly type 1 receptor. So it will not allow the angiotensin 2 to work. Now what is the role of angiotensin 2? It is going to cause vasoconstriction. So if I block that, you will see vasodilation. Now what happens if there is vasodilation? There is decrease in total peripheral resistance, and that is how we decrease the BP. Not only that, it also decreases the levels of aldosterone, and also it decreases catecholamines level like adrenaline, norelin. So it decreases cardiac output directly? No, that is done by mainly beta blockers. It increases sodium excretion via loop diuresis? No. Decreases peripheral vascular resistance? That is a correct answer. Directly blocks beta 1 receptor? No, that is done by beta blockers. So the best answer is, obviously most of you would have written, it decreases peripheral vascular resistance. Correct? Yes. Moving on to the next question. A 12-year-old child presents with palpitations, tremors, dry mouth, mydriasis, tachycardia, and respiratory rate of 34. Which is the following substance most likely responsible for these symptoms? Now, taking into the consideration of a child and checking palpitations, tremors, heart rate, which is the poison? How do I come to the answer? Remember, what is propranolol? Propranolol is a beta blocker. So beta blocker, they decrease the heart rate. So this is ruled out. Physostigmine, it is an inhibitor of cholinesterase. So it increases acetylcholine. So if it increases acetylcholine decrease the heart rate, because parasympathetic decrease heart rate. So these two are ruled out. What we are left out with is lithium. Lithium we give it if there is mania or bipolar disorder or hypnic headache. But how do we know lithium toxicity? There will be coarse tremors. Patient will have tinnitus. Patient will have diarrhea. Patient may develop seizures. So these symptoms are not given. Then what is remaining is tricyclic antidepressant. Particularly what I suspect in this child is he may have been put on imipramine. Why? Imipramine is a drug given for bedwetting. So what is TCA going to do? What is TCA going to do? Let me tell you, TCA, tricyclic antidepressant, I have discussed that plenty of times. They increase serotonin levels, they increase noradrenaline levels in the brain. But they also block alpha, leading to hypotension. They block histamine, leading to sedation. But they also block muscarinic, leading to dry mouth, blurring of vision, tachycardia, and mydriasis. So this is the TCA poisoning typically seen when we give imipramine for children for managing bedwetting. What is the antidote for this? The antidote name is sodium bicarbonate. I repeatedly told in the classes, drug poisoning antidote, they will test you in almost all type of exams. So the answer will be A, tricyclic antidepressants. Moving on to the next one. OCP, oral contraceptive, does not reduce the risk of which cancer in a female? So remember, in a female, the upper ones. So it increases the risk of two cancer, the breast and cervical cancers. Remember, the breast and cervix, the neck, cervical region looks like neck. So they are upward, they increase that cancer. Now the ovary is down, endometrium is down, so endometrium. So these cancers are reduced. So the question is, which will not be reduced? It will not reduce the cervical cancer. Cervical cancer risk is increased by OCPs. They can reduce ovarian cancer, colorectal cancer, endometrial cancer, but never cervical cancer. So the appropriate answer will be cervical cancer in this patient. Moving on to the next one, a patient visited a hospital with black discoloration in buccal cavity and nasal area. So black discoloration, and patient was having high history of steroid therapy. So I think they have taken a old question from COVID period. So this is nothing but the black fungus or mucormycosis. What is the suitable treatment? So for mucormycosis, we have three options. We can give LAMB. LAMB means liposomal amphotericin B. Recently approved drugs like posaconazole, and one more is isavuconazole. So among these three, the best one will be liposomal amphotericin B. Griseofulvin is the best one for tinea capitis. Liposomal amphotericin B is the best one for mucormycosis. Fluconazole is the best one for candidiasis. Voriconazole is the best one for invasive aspergillosis. So here the answer would be B. And we have discussed plenty of times the fungal infection and a drug of choice. So again, an integrated question with microbiology and pharmacology. Moving on to another question. A patient is brought to the emergency department with signs suggesting opioid poisoning. What is the antidote? So antidotes are commonly asked nowadays. Flumazenil is for benzodiazepine overdose. The answer is naloxone. So naloxone is an IV drug which can be given. Suppose they are given naltrexone also, then obviously we will not choose naltrexone because it's an oral drug. The best one will be naloxone. Physostigmine is for atropine poisoning. For atropine is used for OP or carbamide poisoning. So here it is naloxone is the best answer for this question. Again, moving on to the next question. A patient with liver cirrhosis present with bleeding esophageal varices. You know that when there is cirrhosis of the liver, the blood vessels, the portal circulations will get affected. The blood vessels dilate, esophageal varices. The risk is esophageal varices can have bleeding episodes. Which of the following drug is to control the variceal bleeding? So we should use a vasoconstrictor. So which is the best one? I can either give terlipressin or I can give octreotide. So if both are given, I will go with terlipressin. Furosemide is a loop diuretic. Octreotide is the best one we can choose. Propranolol is for prophylaxis, not for acute management. Vasopressin, we are not using, it is non-specific. If they had given terlipressin, we would have chosen because terlipressin is V1 selective, which will cause vasoconstriction. Vasopressin is non-selective, so the answer will be octreotide, that is used to treat acute variceal bleed in this patient. Moving on to the next question. Again, this is a repeated one. A schizophrenic patient developed dystonia and abnormal posture after starting an antipsychotic drug. Obviously, when we start typical antipsychotic, the first thing is acute dystonia. Why acute dystonia? Because when you block dopamine, the acetylcholine level goes up. So that will lead to a problem called acute dystonia or oculogyric crisis. So what is the treatment? Treatment is to decrease acetylcholine, and these drugs are called central anticholinergics. So let us read the question. He was given treatment for that with a drug, later developed dry eyes, dry mouth, mydriasis, urine retention. Which of the following drug implicated in causing this later symptoms? So I told you, when we want to manage dystonia, we give the drug which decrease acetylcholine level. The central ones are benzhexol, or you can give benztropine. Two benz are there. We have one more, bipyridine, or we can give promethazine. All these three drugs, they have anticholinergic property. So when we give these drugs, they decrease acetylcholine. It's like atropine-like action, so they produce dry mouth, blurring of vision, tachycardia. So which is the drug implicated in this? Quetiapine is atypical antipsychotic, which causes less problem like this. but it is not going to cause dry mouth mydriasis. So what is the best answer? Benztropine. Clozapine, you have to revise the adverse effect of clozapine. It can cause sialorrhea, wet pillow syndrome. It can cause agranulocytosis, and it can lead to myocarditis, and high dose can lead to seizures. Haloperidol is a typical antipsychotic. So typical means it blocks D2. So it can increase prolactin and it can increase the risk of extrapyramidal symptom. So this same question they are repeating, but if you know the concept, you will crack this. Right, very good. Next question. A 60-year-old patient is on 3 antihypertensive for hypertension. 3 antihypertensive. One should be diuretic, is resistant hypertension. He is having uncontrolled BP and hypokalemia. So his potassium is also low. Which of the following drug is used in next step? So we know that first line drugs for hypertension is ACT. We give ACE inhibitor or ARB, CCB or thiazides. Still not controlled resistant hypertension. We know the drug of choice is spironolactone. But here the patient is having hypokalemia. Nitroglycerin we don't prefer as the drug of choice for resistant hypertension. Spironolactone will be the appropriate because it is the drug of choice for resistant hypertension, and also it can increase potassium in this patient because he is having hypokalemia. Furosemide is not appropriate because furosemide can cause hypokalemia and worsen the problem. Potassium chloride supplementation not required. So just add spironolactone. It will take care of hypertension also. It will take care of hypokalemia. So that is the best answer we can choose. Clear? Yes. Again, there was a case of complicated malaria. I have told you, repeated in the class. Read malaria, one or the other exam, they keep on asking. Due to endemic Plasmodium falciparum, resistant to chloroquine, treatment of choice in first trimester of pregnancy, whether they are pregnant or non-pregnant patient. What is the drug of choice for complicated or cerebral malaria? It is artesunate, which is given IV. So IV artesunate is the drug of choice for this. Coming to another MCQ, a tricky one. Tricky one. Usually they should not ask like this, but this time they had asked this question. Women taking cetirizine for allergic rhinitis, complaints of excessive sleepiness. Usually cetirizine belongs to second generation. According to textbook, they don't cross blood-brain barrier and there should not be any sleepiness sedation. But everybody have experience taking cetirizine, sedation has occurred. So which of the following is the best alternative for minimal sedative effect? So what is the alternative? Hydroxyzine, diphenhydramine, promethazine, fexofenadine. Hydroxyzine is also first generation, so it will worsen the problem. This is also first generation, this is also first generation. So all these three are avoided. Then what should I give? I should give second generation antihistamine, fexofenadine, which will not cross blood-brain barrier and it causes least sedation in this patient. Yes, so we discussed that in the class. Again, this is a repeated question. Which is the preferred preoperative drug for managing blood pressure in a patient with pheochromocytoma? So before surgery, you want to manage hypertension. The drug what we use is alpha blocker, phenoxybenzamine. Phenoxybenzamine I should use. Intraoperatively, if you want to manage, we use a drug called phentolamine. And please remember, when you manage pheochromocytoma, always you have to give alpha blocker followed by beta blocker. So this is very, very important. I don't know whether this question was there, but some student told me, so I am telling you this. 35-year-old male present with lesion shown below in the axillary region. He reports that similar rash occurs at the same site every time he takes cotrimoxazole, a sulfur drug. The lesion is mildly itchy and heals with darkening of the skin. What is the mild likely diagnosis? It cannot be drug allergy. So if it is happening in the same place again and again after the drug is being taken, we call it as fixed drug eruption. And this is a NEET PG repeated question. It's a fixed drug eruption. Contact dermatitis usually happens if we are giving drug as a patch. Immunological drug reaction is not the answer. This is fixed drug eruption. See, so many questions are from hypertension. Let me read out. 39-year-old IT employee, Male present with symptom of headache and giddiness, yes, stress and inability to manage work-life balance. An evaluation is average blood pressure is around 150/95 on 3 different clinical visits. Yes, when you check the BP, it should be on 3 different occasions. I don't know whether they have given the question like this, or if the BP is uncontrolled or high BP. If they are given high BP and patient is 39-year-old, younger, what is the most appropriate next step in management? Now start thiazide. Remember, thiazides are only mild antihypertensive. They decrease only 5 millimeters of mercury. So patient, if he is having high BP, this you can start, but you have to add one more drug. Start telmisartan. Yes, telmisartan can be started in this patient. Telmisartan can be used in this patient. Why do you want to give steroids? No. Otherwise, rest only, no pharmacological treatment. See, if the patient is having high blood pressure on 3 occasions, it is obvious that you have to start the patient on antihypertensive therapy. And patient is having stress, headache, giddiness, everything, so you have to start. So why not thiazide is not the answer. I told you it's a mild one. If you want to give thiazide, you should have added one more drug. Usually certain guidelines tell you if the age is less than 55 years, you go with AC inhibitor or ARB. If the age is more than 55 years, then go with C series. Then thiazides come later. So start telmisartan in this patient. This is again a clinical question. So there is a big question given here, but they are given a SCAR and patient is having scrub typhus. What is the drug of choice for scrub typhus? It's an integrated question with pharma and microbiology. If you are diagnosed scrub typhus, what is the drug of choice? The drug of choice is doxycycline. I think we came across plenty of questions from pharma. I think most of them were from PYQ discussions, previous year topics discussion, except 1 or 2 confusing options, particularly the pharmacokinetic question or some asthma confusions. I think most of them were moderate, not difficult questions. So any queries you have, you can approach me in my Telegram group or follow me on Instagram. So any other options change or anything you want to ask me, you can ask me in the YouTube section, comment section. So thank you all the best for your results, and those who are watching it later, this video is going to benefit you for the important thing you need to learn from this video. How the questions are asked, you will learn from that. So it will be beneficial for both NEET PG as well as FMG people. Thank you all. Take care.